So, whoever is sitting at the controls, could you please press the record button for this? I guess starting now. So this week I plan to talk brief. All the talks are intended to be brief, but I plan to briefly talk about the topic of atypical or non-characteristic hallucinations in schizophrenia. This topic came about following some discussions with people in the learning community around the question of, does somebody who talks about something like, for example, a well-formed ghostly apparition that is the soul of a departed family member who was abusive in childhood, who talks all the time, and so forth, is that very detailed and sort of pervasive and deeply meaningful hallucination report this to be given the same weight as somebody who is, say, 19 years old and has a sudden onset of a running commentary in the form of a voice that sounds like it's coming from outside of his or her head, talking about what they're doing and saying derogatory things. The two different hallucinatory experience reports seem very much different, and the question is there anything to that in terms of helping to think about diagnosis or treatment? So that's the question I'm going to try to answer during today's talk. And since we're going to talk about unusual hallucinations, I'm first going to talk about what exactly is a hallucination and what kind of hallucinations, if any, would be typical of people with schizophrenia. So hallucinations for 200 years have sort of gravitated around the similar concept, the perception of an object or event that in the absence of an external stimulus. And so here you have quotes from 1845 to 2009, which use slightly different language, but say the same thing. So hallucinations are perceptions without external causes. And we know that hallucinations are common in schizophrenia. Actually, they're common in psychotic illness. They're a defining feature of psychosis. And let's think about first, though, what causes them. These days, we're getting pretty good ability to localize brain activity. You can do this through looking at EEG recordings, which measure brain waves. You can do this by looking at functional brain imaging, such as functional MRI or PET or SPECT scans, which measure glucose metabolism. And through a number of different approaches, we've learned that there are many causes and they're a bit difficult to track down, but generally data are converging around hallucination. The experience of hallucination seems to correlate with activation of areas of the brain that serve that perception. So in the case of auditory hallucinations, there are areas of the brain in the temporal cortex that are called auditory association areas. So the job of these regions of the cerebral cortex is to create the experience of sound and understand the meaning of sounds. And those areas can spontaneously activate, it would appear. Association areas that are devoted to sensations can become overactive or inappropriately active for at least three different reasons. One is that there may be inhibitions of input, so the normal inputs to that area are diminished. And in the absence of some external signal, that area of the brain begins to generate its own signals. It can become hyperarousable and sort of misfire. And when these association areas of the brain misfire, they create sometimes complex perceptions of sensory experiences. So that's one pathway. Another pathway that you can get to the same phenomenon is to actually have an enhanced input. So when you have overdrive inputs into these association areas, then the association areas can fire inappropriately. And another way to get spontaneous activity in association areas is based upon computer modelings of neural networks. And we find that as we diminish the number of connections between processing nodes in the computer network, which would be akin to reducing the synaptic connectivity between neurons, that those neural network systems begin to spontaneously generate output signals. And so that's another hypothesis as to how we can arrive to hallucinatory experiences in psychosis. So now that we understand what they are and have some hypothesis as to what causes them, what are the typical hallucinations in people with schizophrenia? And here you have a table. This is from a relatively old study by Kim Muser and Associates from 1990. The studies that have been similar design have come out with roughly the similar data, which says that according to this table, the overwhelming experience, the most common experience of hallucinations is auditory. So in parenthesis is the percentage of people experiencing this in the sample. 70% experienced or reported auditory hallucinations. Visual hallucinations were present in this sample in 16%. Some estimates take it up to about 30%. And then tactile or olfactory or gustatory, so hallucinations of sensation or of touch or of smell or of taste are less common, but less common is still pretty common. 10% to 20% of people with schizophrenia reported hallucinations in those sensory modalities. So the next question is, does the presence of a specific type or form of hallucination, can we use that to forecast or predict diagnosis? Can we use that to predict diagnosis or to forecast treatment response? And sadly, probably not. This is a relatively recent 2016 meta-analysis looking at a large number of studies that try to address that question. And highlighted in red, highlighted in yellow, is that amongst the features of hallucinations that were considered, 95% of them were shared with other psychiatric disorders, and 85% of them occurred in medical or neurological conditions. So it's not, we can't say that detailed and somewhat dramatic, fully formed visual hallucinations will point you to, say, a trauma-related psychosis diagnosis with any more reliability than anything else. Even as much as it seems like it might make sense, that's not apparently supported by the data. It's also, I probably should have put this tidbit in the previous slide, but amongst people that have schizophrenia, more than half of them experience hallucinations in more than one modality. So not just auditory, but may include also visual or tactile hallucinations. So we're left with, despite the attractiveness of the question, we're left without a whole lot of data to lead us to say that a visual hallucination leads to a different diagnosis than a auditory hallucination. That said, there are some things when we hear about these less common hallucinatory modalities, visual, tactile, olfactory, and so forth. There are things that we should know and that we should consider as we do our assessment. So I'm going to, there's the most data pertaining to visual hallucinations. So I'm going to go through, if you will, key learning points or key pearls around each of these things. Visual hallucinations, in people that have delirium, visual hallucinations are the most common kind of hallucination, and delirium, as remember, is a sort of global confusional state that can be caused by infection or metabolic abnormalities or substance intoxication or withdrawal. Bullet point number 2 is specifically about intoxication withdrawal. So with delirium, almost any drugs can lead to delirious experiences, but outside of impaired neural substrate or infections which would predispose one to delirium, drugs that are known to cause hallucinations are known to cause visual hallucinations are the hallucinogenic drugs like LSD or mescaline. And related to delirium, visual hallucinations are relatively, they're not unheard of and somewhat common in alcohol withdrawal psychosis, or what was used to be known as delirium tremens. If you learn of an adult that's experiencing visual hallucinations, regardless of age, you should consider Lewy body disease, and Parkinson's disease. Uh, Visual hallucinations are especially prominent in Lewy body disease. In somebody among the common causes of visual hallucinations in people who are more than 60 is diminished visual input. Remember, if we don't drive the association cortex with fresh input, that cortex is likely to generate its own firings, and so having cataracts is a frequent cause of visual hallucinations, or misperceptions in people more than 60. There can be certain kinds of epileptic activity that can cause visual hallucinations as well. Um, Stroke lesions, and the most common lesion being stroke in the midbrain, particularly in the cerebellar peduncles, are a reliable cause of visual hallucinations. Also think about tumors, especially, and when tumors do this, it's not so much by pressing on the brain, but it's by triggering abnormal electrical activity, so by producing epileptiform activity. Migraines will classically have halos, or occasionally patterns, but even more occasionally you can have more formed visual hallucinations, getting down to very rare Creutzfeldt-Jakob disease, or children who have one of those inborn errors of metabolism can sometimes present with visual hallucinations. Learning point for students, or those who have to take examinations at some point, a couple of acronyms, no, eponyms attend visual hallucinations. Charles Bonnet syndrome is the phenomenon of visual hallucinations in people that are blind. And a bit of the opposite of Charles Bonnet is Anton syndrome. That think of that as an anosognosia of blindness. People who are definitely blind will insist that they can see things that physiologically they shouldn't be able to. There is a phrase called Lilliputian hallucinations, which I really like, and it is I like the name. And it involves seeing small people, and amazingly, I didn't know this, that they have done studies of the size of hallucinated individuals during Lilliputian hallucinations. So the official scientific definition of Lilliputian is 4 feet or less. So there you go. Very, very rare to see this in schizophrenia, but very common in alcoholic or toxic psychoses. And note, especially anticholinergic drug activity. So if you do see somebody with schizophrenia who's talking about seeing little people, do check and see if they are on an anticholinergic drug, and look at that. Okay, moving on to another special hallucination class, musical hallucinations. Very uncommon in schizophrenia, very uncommon across the board. When they do happen, they're often in the form of songs, and we should consider lesions in the auditory pathway, as well as temporal lobe epilepsy. Olfactory hallucinations are more common certainly they're more common than musical hallucinations. They can be what I call purely psychiatric. In other words, that they can be directly related to diagnoses such as schizophrenia, or depression. Those are the more common conditions that can lead to olfactory hallucinations. Once in a while, they can be pleasant, and I suppose if they're pleasant, we don't hear about them as often, but more frequently they are disgusting, involving like putrid or decaying flesh, or burning hair, or kind of noxious chemical smells. And when this happens, again, look for the usual psychiatric diagnoses, but also consider things like polyps or lesions of tumors in the olfactory bulb or olfactory pathways. Also, they can occur with migraine auras, as well as during seizures and Parkinson's disease. In fact, I saw one paper that cited about 7% of people with Parkinson's disease will report olfactory hallucinations. Tactile hallucinations, hallucinations of sensation. These are from apparently sensory cortical activity driven by thalamic dysregulation. The most common form of tactile hallucination is formication, which is the sensation that you have insects, bugs on your skin, and the close cousin of that is parasites wiggling around in the skin. They can occur with several forms of dementia, Alzheimer's, Parkinson's, and Lewy body disease. And anytime, I mean, and they can occur with schizophrenia, to be clear, but they are especially common with stimulant intoxication or with alcohol withdrawal. So when I hear somebody with formication experiences, I keep an open mind, but I first want to rule out substance intoxication or withdrawal as my first pass. So coming back to these fanciful, fully formed, very meaningful, hallucination reports that don't seem typical of what we usually hear in psychotic illness or schizophrenia. We should also consider malingered psychosis, and in these visual hallucinations are far more often reported in people who are malingering psychosis than are offered spontaneously from people who are experiencing schizophrenia. When they are dramatic or atypical or continuous rather than intermittent, these should arouse suspicion. Usually when people have hallucinations, the mind wants to make sense of it. So if I begin to hear voices, then I'm trying to think, how is it possible that that happens? So I come up with beliefs to explain it. There are microphones behind the wall, there's a radio in my pillow, there's chips in my head, whatever. But that belief will be a delusion. So it's very common that hallucinations occur with explanatory delusions. And when you have hallucinations without some kind of patient-generated explanation for it, that's also suspicious. And I should point out here that malingering is defined as the production or the feigning of symptoms for secondary gain. Usually we think of this as wanting to avoid punishment or get disability, or maybe um, to deliberately assume a sick role. But related to that, it can be a way of trying to express to clinicians that a person is really suffering. So if you have somebody who's giving you these very elaborate stories that don't make sense, do try to keep in mind that this very well could be a person who is very much in need of assistance and care, and this is a way that he or she is attempting to get that. So to summarize, so people with schizophrenia can experience hallucinations in any modality, as much as it would make sense. The way we've defined things and the data so far don't point to an ability to for a specific type of hallucination to point to a specific kind of diagnosis or treatment. They are simply one symptom data point, and we should consider reports of hallucination along with the usual things: the history of present illness, the past medical and past psychiatric history, social history, laboratory, physical and neurological examinations. And my 2 cents is, when you have reports of hallucinations that are common, visual, olfactory, gustatory, and so forth, that I think the urge to do neurological examinations, including imaging, probably rises significantly higher in importance. And that is, I think those are my comments on atypical